Rahim. Uh, so today's session is regarding the orbit, and we have a number of presenters today. We'll start with Tayyib Bhagwani Saab on congenital tumors of the orbit case series. Before starting this session, we're going to start with the dua.
बिस्मिल्लाहिर्रहमानिर्रहीम। हमारे कुलीग ज़ीशान कामिल साहब के वालिद साहब पिछले दिनों इंतकाल कर गए, इन्ना लिल्लाहि व इन्ना इलैहि राजिऊन। तो सबसे दरख्वास्त है कि उनके लिए सूरह फातिहा और कुल शरीफ पढ़ के उनके लिए इसाले सवाब करें। बिस्मिल्लाहिर्रहमानिर्रहीम, अल्हम्दुलिल्लाहि रब्बिल आलमीन। सल्लल्लाहु अलैहि वसल्लम। अल्लाह ताला मग़फ़िरत फरमाए। बिस्मिल्लाहिर्रहमानिर्रहीम। I will be talking about the congenital cancers, not the tumors, but the congenital cancers of the orbit. And the objective of the presentation is to highlight this rare occurrence. It happens. And by congenital cancers, by definition, there is no strict definition, but that presents at birth or within few months of life. So we will be discussing some of the congenital cancers which we came across. यार ये आगे नहीं चल रहा भाई, किधर से होगा यही? So malignant primary orbital tumors are extremely rare, and the current study will highlight some of the tumors which we came across and also the challenges that are associated with the management of congenital cancers. यार ये तो मैं दबाता ही रहूँगा, मेरी ये प्रेजेंटेशन का टाइम ख़त्म हो जाएगा। नहीं इसका भी बस। सो पीछे चले ज़रा, मिस कर गए आप, पीछे चले। और पीछे, और पीछे। हाँ नेक्स्ट, अब यहाँ से नेक्स्ट शुरू करें। Over the last years, 20 years at Al Shifa Trust Eye Hospital, Rawalpindi, there were around 1200 space-occupying lesions of the orbit, which means pure orbital tumors. These are 1200 are pure orbital tumors. 1200 and 500 of these lesions were in children, which means that about 40% of the orbital space-occupying lesions were from children. Next, please. So in this is a pie chart. 94% of the orbital cancers. This is congenital orbital cancers at birth. 6% of the orbital cancers were at birth, while the rest of 94% were later on. And in children, there were 500 lesions, out of which 100 were malignant lesions, and out of those 100 malignant lesions, 94% presented later and 6% presented at birth. Next, please. So what were the lesions that we came across? These are the three type of lesions. Rhabdomyosarcoma. There are 4 cases of rhabdomyosarcoma, 1 case of Ewing sarcoma, and 1 case of very rare, not reported before, primitive myxoid mesenchymal tumor of infancy that has also been published internationally. Next, please. Next. So this is the case of congenital rhabdomyosarcoma. Child presented at birth, a very big tumor, Can see that different views. Next, please. This was the pre-operative picture. This is the tumor removed, and that is just for operative post-op picture, post or surgical picture. The child survived for 5 months. Next, please. This is another case of congenital rhabdomyosarcoma, but this is a success story. The patient, the tumor along the lateral wall of the orbit, and then this is a pre-operative, post-operative, later on recent. So about 3 years follow-up. The child after congenital rhabdomyosarcoma is surviving. Next, please. So congenital Ewing sarcoma was the next tumor, and this is a pre-op. You can see the picture here along the medial wall and the intraconal lesion. Next, please. Next. Move नहीं कर रहे. So today you have to वापस चलेगा. So next. Right. So Ewing sarcomas and peripheral primitive neuroectodermal tumors are two types of malignant tumors that are histologically characterized by presence of small round cells in soft tissue. This primarily occurs in children and adolescents, but extremely rare in newborns. These tumors originate from the neuroectoderm and are composed of undifferentiated or poorly differentiated neuroepithelial cells. Next, please. To date, over a dozen newborns with congenital PNET or Ewing sarcomas of soft tissue have been reported, and the prognosis is very poor, and most of the infants do not survive beyond 2 years. So that's why people not here in Pakistan but elsewhere, they also advise judicious fetal screening. It's very important, and when a fetal soft tissue mass is revealed by prenatal ultrasound, this should be suspected. This tumor should be suspected. Next, please. Usually, if we are able to see during prenatal screening performed as needed, there should be a reasonable intervention timely involving radical section can also be done. I mean, the surgery during the fetal period has also been is one of the choices. Next, please. This is a primitive myxoid mesenchymal tumor of infancy. The next tumor. You can see the patient here. The imaging shows intraconal tumor which is surrounding the optic nerve. Here it is. This is the you can see the violet colored tumor, and it was oozing with mucus when it was removed. We took only the biopsy, and the child was followed up for almost I think 1 year. And this is as I will mention later, is very aggressive locally. It does not metastasize, not has a potential to metastasize very rapidly, but locally it is very aggressive. And since this was the first tumor reported in the literature, which was the primitive myxoid PMMTI, that was associated with optic nerve, not arising from optic nerve, but it was all around it. And only one orbital PMMTI has been reported before, but that was along the lateral wall of the orbit. So next, please. So PMMTI is a rare mesenchymal tumor of early childhood characterized by aggressive local infiltration. As I mentioned, rare metastases, surgery alone to be the most effective treatment, and response to traditional chemotherapy is not very good. Originally, these tumors were labeled as sarcomas, but immunohistochemical and genetic analysis has now categorized the tumor into a definite entity. Next, please. Now, these are the tumors which we came across. Uh, 4 cases of rhabdomyosarcoma, congenital rhabdomyosarcoma, 1 case of Ewing sarcoma, and 1 case of PMMTI. So, out of, so many cases, this is quite rare occurrence, but still it is an important, significant element. Newborns, this is extremely uncommon. Primary malignant tumors have described rare primary malignant tumors in newborns, including the others have included, the studies have shown malignant orbital teratoma, congenital neuroblastoma, congenital orbital rhabdomyosarcoma, and desmoplastic small round cell tumors have also been reported at birth or within few months of the birth. Next, please. And the problem challenges are that it's difficult to detect any orbit abnormality by prenatal ultrasounds. It's not that easy. And massive proptosis at birth is the main symptom, as it was in most of our cases. Next, please. Rhabdomyosarcoma is the most common malignant tumor of the orbit, but still it is rarely present at birth. And these rhabdomyosarcoma congenital syndromes are associated with congenital rhabdomyosarcoma, such as these are some Lee-Fromeni, and then neurofibromatosis type 1, Noonan, Gorlin, Costello, hereditary retinoblastoma, and this Beckworth-Weidman syndrome. Our patients did not have any sign of the above mentioned syndromes. Next, please. What is the challenge now? The important is it's not only the surgery that we complete and then as surgeons we do and then move on, but it is the tumor, the treatment afterwards, adjuvant therapy, which I talked about in detail yesterday, is adjuvant therapy, which is very important. And now, the challenge is the child is newborn, the chemotherapy is toxic, radiation dose is got collateral damage. So what to do? So dosing regimens for the treatment of infants and very young children with cancer represents a major challenge. Dose reductions are commonplace for many chemotherapeutics in this patient group, and appropriateness of dose reduction for drugs is unclear. Now, when you reduce the drug, what is the problem? When you reduce dosage, of course, the effect may not be the same, and there may be treatment failure. So that is, these are some of the problems. Next, please. There is a limited data concerning anti-cancer drug disposition in the neonatal patient population. There is a complete lack of data generated from studies within the first few weeks of life for all but a handful of anti-cancer drugs. That is a limitation. We really do not know the behavior of these anti-cancer drugs in the neonatal period. Next, please. Next. So sometimes because of these challenges, the treatment may be omitted, or there may be disintensification of treatments. Doses is reduced, and that's why the treatment failure rate is increased. In our cases, all the treatment regime, the adjuvant therapies were delayed in all the cases. So individualization of therapies in infants is commonly practiced, and then you have to tailor the therapies to each patient. In delayed surgery, either you delay the surgery with induction chemotherapy, withhold or delay indicated radiation treatment, and altered chemotherapy regime or dosing.
Sir, please conclude it.
Okay. Next, please. जो इनको इंटरप्शन की है वो थोड़ा सा टाइम देना चाहिए. Next. So, conclusion, RMS is the commonest congenital cancer of the orbit, and about a dozen types of congenital orbital cancers have been reported. Treatment of malignancies in infants and very young children requires a careful balance between optimizing disease control and minimizing late toxicities that can significantly impact long-term function and quality of life. Next, please. So these are some of the advances in technology which can help. Proton therapy has got, and image guidance allow more conformal radiotherapy. and that less collateral damage and outcomes for these young patients. Next, please. Excuse me. Next, if there is any. Thank you very much.
Now I would like, and his topic is management of maggots infestation in orbital tumors.
नहमदुहु नसल्ली अला रसूलिहिल करीम बिस्मिल्लाहिर रहमानिर रहीम। इसमें यहाँ भी आ जाएगा ना ये? ठीक, जी कोई बात नहीं सर, जिंदगी अपनी गुजर जाएगी आराम के साथ, अब मेरा नाम भी आएगा तेरे नाम के साथ। जज़ाकल्लाह। सबसे पहले तो मैं शुक्रिया अदा करूँगा ओकुलोप्लास्टिक टीम का कि वी हैव गॉट नाउ 3 generations of orbit and oculoplastic surgeons in this. I am house surgeon of Professor Tayyab and Aftab Saab, and I've learned a lot from all of them. And now we can see that Sadia, who is now my fellow, and now the other young fellows from Saudi Arabia are here. So this is a galaxy, and I love something about oculoplastic is that we have got such a peaceful debate and discussion, which other forums they don't have. Right click पे होगा move? जी नहीं वो है ये। I was King Edward Medical University has got a unique program of emergency department, and it is recognized for fellowship and MS program. उसके जो चेयरमैन हैं उनकी मुझे कॉल आई कि वी हैव ए पेशेंट एंड 68 years old male and he is in the emergency. His conscious level has improved, but there is no carer. Nobody recognizes him, and his conscious level was better now. And he said, do something about it. He's got a large orbital problem. We don't know what it is. So when we examined, this was the status. And on top of that, he was an IV drug abuser. तो वैसे ओकुलोप्लास्टिक वालों के साथ मैंने ये भी देखा है कि अल्लाह ताला की ख़ास रहमत भी होती है कि वो 3 दिन से वहाँ पड़ा हुआ था इमरजेंसी डिपार्टमेंट में, कोई उसका ख्याल नहीं कर रहा था। तो जैसे ही वो हमारे आई डिपार्टमेंट में आया तो उसकी भतीजी आ गई। वो बेचारा अनमैरिड था, इस तरह की कोई इशू था, और the whole family started taking care of him. He used to live alone. ये प्ले कर देंगे जी हम, आई होप राइट। तो ये जरा देखिएगा, प्ले, हाँ आप करें। ये देखिए, ये आपको कुछ कुलबुलाते हुए नजर आ रही हैं चीजें। इट इज वेरी डिस्ट्रेसिंग। कई हमारे हाउस ऑफिसर बेहोश भी हो जाते हैं जब ये ऐसा मंजर नजर आता है, लेकिन वी हैव टू डील विद इट। आप लोगों में कईयों ने तो देखा होगा, सीनियर्स ने तो सारों ने, कोई यंगर लोग, क्यों जी, हैदराबाद में भी, और आपके साथ जो बैठी हुई हैं इन्होंने तो ये एक स्टडी भी की है। ये भी हम इनकी स्टडी कुछ या वो हम शेयर करेंगे, डाटा आप भी कमेंट कीजिएगा। ये उल्टा जाना शुरू हो गया। और ये मैंने आयत लिखी थी, रब्बे अरहमहुमा कमा रब्बे यानी सगीरा, कि जो हमारे अल्लाह ताला हमारे माँ बाप पे भी उसी तरह रहम फरमाना कि जैसा उन्होंने हमें जब हम कुछ नहीं थे उन्होंने हमारे लिए किया। So that brings us to ophthalmomyiasis. External, most of the time we deal with it, but it can be internal, subretinal as well. and it can progress relentlessly. They are, they can eat up the tissue very quickly. That was the typical scenario we told you, and these are the different factors which contribute towards it, and we have got all of these factors in our country. But also the urban slums, they also have this problem. But the main area we see is this one: compromised setting and malignant disorders and poor hygiene together. It's very, very difficult to treat, and it takes a lot of resources. So it is better to prevent it and create an awareness about it. I don't know if President of Oculoplastics Association here, sir, would it be appropriate to make a short video and show it to the public that this can happen? I don't know. We can discuss later in the meeting. But we can make a small YouTube video, and we can tell the people that if there is some lesion, they should not neglect it. So this is the typical management plan, and I think we should focus more on it. Well, what do you do if you get the patient? And the tricky thing about it is that these are very, very photosensitive. As soon as you switch on your microscope, they hide. We have here Farzad Pakdil. Please come forward. We want your opinion regarding the presentation. And strongly hold your bag tight. We don't want to take any risk. Thank you very much. Farzad is from USA, and we are very grateful for him to be visiting Pakistan. And I hope he also has enjoyed the meeting. So it is perhaps first of all you anesthetize them so that the maggots, we are discussing myiasis for that, so that they slow down. Otherwise they are very fast and they are very forceful as well. You hold them and they are very forceful as well. You hold them and they have tentacles all over the place and they don't come out. And if it is broken, I think it is more toxic. So minimum light of operating microscope, or maybe use a loop, because there is a large area, loop with diffuse light, and slowly and steadily pull them out. And obviously you can start, you need to start the antibiotic, anti-inflammatory treatment, analgesic. This also help if you apply some suffocating agent that covers their body and they're not able to breathe. I think they, through their skin, they are breathing. It's coming up in the literature. I don't know, we don't have much experience. We haven't used for myiasis. You have?
Especially in those with after radiotherapy or tumors or neglected tumors that ophthalmologist happens in tissues, necrotic tissues. So it's not
right. Okay.
It's not working. So I'm saying that cases like in exaggerated patients or large tumors, necrotic tumors. So it happens like that usually.
So sometime we have to go from enucleation to exenteration, or maybe extended exenteration. We have a cohort of 15 patients over the last 5 years at Mayo Hospital, and we use turpentine oil to paint. These are most of the time they have BCC because it is neglected. Most of them they have diabetes and hypertension, other comorbidities. And these are the references. And this is the team which work together because it's not possible to remove all the maggots on one day. Sometimes we keep the patient in for couple of weeks. So, and there is duty of one PG who has seen where they are hiding to remove every day. And this is my son, and we are trying to convince him to join medicine. He says, I want to become a scientist. Thank you.
Unfortunately, Professor Zishan Khalid could not come due to the demise of his father, but I think his resident is here. Dr. Rizwan will be presenting of fertility in dermis fat graft. He's going to be discussing about surgical approach to the orbit.
Assalamu alaikum. My name is Dr. Rizwan Rashid. I am a plastic fellow at LRBT Eye Hospital, Karachi. Today, I am going to present surgical approaches to orbit on behalf of Professor Zishan Kamil. Next. Okay. Orbital surgery requires delicacy of neurosurgery, strength of an orthopedic surgery, three-dimensional sense of general surgery, comfort and success depend on anatomical knowledge. Surgical spaces. There are 5 surgical spaces: subperiosteal surgical space, extracorneal surgical space, episcleral surgical space, intracorneal, and the subarachnoid surgical spaces. Okay, orbitotomy. What is orbitotomy? Operation referred to a surgical approach for an orbital mass lesion. There are 4 types of orbitotomy: anterior, lateral, transfrontal, and the temporofrontal orbitotomy. Okay, come to the indication of anterior orbitotomy. Lesion in palpable through the eyelid, mainly in front of the equator of the eyeball. Okay, the anterior orbitotomy further divided into superior, inferior, medial, and the lateral approach. In superior approach, prefer for the location located in the superior anterior part of the orbit through transcutaneous route and the transconjunctival route. In transcutaneous incision through the upper eyelid crease offer good access to the superior orbital rim and the periosteum with the buried scar. Cosmetic outcome is better in an eyelid crease incision. In transconjunctival approach to reach the episcleral, intracorneal, and extracorneal surgical spaces, but dissection must be performed medial to levator muscles to prevent ptosis. Vertical eyelid splitting of the upper lid at the junction of medial and the central third allow extended exposure to remove intracorneal tumors. Okay. In inferior approach suitable for the lesion located in the inferior anterior part of the orbit as well as the deeper extracorneal orbital mass, also used for orbital decompression or orbital floor repair. Inferior approach also has transcutaneous and the transconjunctival route. In transcutaneous approach, minimal scarring by use of an infraciliary blepharoplasty incision in the lower lid and dissection beneath the orbicularis muscles to expose orbital septum and inferior orbital rim. Extended subciliary incision or an incision in the lower eyelid crease allow exposure to the rim. In transconjunctival approach, incision made through inferior conjunctiva and lower eyelid. Exposure of the floor optimized when incision is combined with lateral canthotomy or cantholysis. Incision of the bulbar conjunctiva and tenon capsule allow to episcleral space. If inferior rectus is retracted, intracorneal space can be accessed. In medial approach, must be cautious to avoid damage to the medial canthal tendon, lacrimal canal coli, sac, trochlea, superior oblique tendon, muscles, inferior oblique muscles, sensory nerve, vessels along the medial aspects of the superior orbital rim. Medial approach has also transcutaneous route, transconjunctival, and the transcruncal route. In transcutaneous approach, tumor with or near lacrimal sac, frontal or ethmoidal sinus, and medial rectus can be approached. Lynch frontoethmoidal incision 9 to 10 mm medial to the medial canthal angle. This is a picture of it. Okay. Transconjunctival incision in the bulbar conjunctiva allow entry in the extracorneal or episcleral surgical spaces to expose the region of anterior optic nerve. If the posterior optic nerve or muscles bone need to be examined, this is the picture. Okay, truncal approach, incision through the posterior third of the truncal or conjunctiva immediately lateral to the truncal allow excellent exposure of the medial periosteum, advantage of better cosmetic results than Lynch. Lateral approach is performed through lateral canthotomy incision. Okay, lateral orbitotomy, come to the indication. Laterally place extracorneal tumor, intracorneal tumor, lateral to inferior to the optic nerve. Also used for lacrimal gland tumor, retroverbal lesion. Previously, traditionally S-shaped, stalwart right skin incision extended from the beneath the eyebrow laterally and curving down along the zygomatic arch allow good exposure of rim but leave an ugly scar. The neoperipheral incision are upper eyelid crease incision, lateral canthotomy incision. This is a picture. Lateral orbitotomy. Okay, come to the indication of transfrontal orbitotomy, superior and medially placed moderate and small sized tumor. Intracorneal tumor medial to the optic nerve. Orbit is open through its roof. Supratrochlear nerve is preserved. Plan should be preferred between the superior rectus and the medial rectus muscle, particularly useful for the tumor of the optic nerve. Okay, come to the indication of temporofrontal orbitotomy. All tumor with middle and infratemporal fossa extension. This approach provides an access to the orbit through its roof and anterior and medial cranial fossa simultaneously. This is the upper lid crease incision, the transconjunctival inferior medial approach. This is the transcutaneous superior nasal approach. This is the transcutaneous superior approach. The medial approach. This can show well demarcated medial side of the orbit.
Please be quick. We are late. Thanks.
Okay, this is a transcutaneous inferior approach. Okay, this is lateral orbitotomy. Okay, post-operative care of orbital surgery, elevation of head, ice compression, steroid administration, placement of drain, regular visual acuity assessment, and avoid patching. Complication of orbital surgery, decrease or lost vision, pain, increased IOP, often pupillary defect, cranial nerve injuries, mortality defect, ptosis, neuropalliatic keratitis, hyperesthesia, and infection. Thanks. Thank you.
The next presenter is Dr. Nasser Kamar, and he'll be discussing fornix reconstruction using amniotic membrane.
Hello, Assalamu alaikum. I'm Dr. Nasser Kamar, working at Hashmani's group of hospitals, Karachi, as a orbit and oculoplastic specialist. Okay, before we start the fornix, the orbit socket is composed of eyelid, the fornices, and the orbital soft tissue and the bony cavity. So the term contracted socket is composed of shrinkage of orbital tissue, reduction in the orbital volume, decrease in the fornicial depth, and the decreased conjunctival surface area. So there has been multiple attempts made to classify a contracted socket, but the most clinically widely used classification are by Gopal Krishna in 1980, and later it was revised by Tawfiq in 2009. So it divided into 5 grades. Grade 0, when there is a healthy socket with deep and well-formed fornices. The normal dimensions are superior 8 to 10, inferior 8 to 10, lateral 14, and medial is 7. Grade 1, when there is a shelving of the lower fornix. Grade 2 is when both the superior and inferior fornix are lost. Grade 3 is involvement of the all 4 fornices. Grade 4 is involvement of all 4 fornices along with the reduction in the horizontal papillary facial length. And grade 5 is when there is recurrence of contraction after repeated failed attempts at reconstruction. So what causes contracted socket? The most common etiology is the poor surgical technique. Always try to secure the healthy conjunctiva after evisceration or enucleation. Failure to wear a prosthetic for a prolonged period, radiation exposure, infection, injury, trauma, chemical burns, prior orbital or recurrent and ophthalmic surgery, autoimmune diseases like Stevens-Johnson's and mucous membrane pemphigoid. So, how do you manage fornix reconstruction? Start with the history and physical examination. The only presenting complaint of a patient is with the time gradually they are unable to retain a prosthesis. Look for the discharge, any extruding implant, eyelid malpositions like entropion, ectropion, ptosis, they has to be addressed. Socket should be assessed for the depth, vascularity, loss of volume, inflammation. There are various methods to measure the depth. There is an instrument named forniciometer, or you can use a needle, blunt needle, and then measure with the caliper, or be as simple, use a ruler to measure. Okay, the management is usually surgical, and it can be staged, single. For when only the fornix are involved, we can deal it with fornix forming sutures and amniotic membrane. And when there is for increased conjunctival surface area, amniotic membrane, buccal mucal graft, and hard palate graft can be done. For volume augmentation, we do fat dermis graft, and we can use silicone expanders. So this is my case. 30 years old male, history of RTVA, presented to me with right eye downward slanting of the upper lid. There is notching. On a closer look, you can see there is extensive fibrosis, granuloma formation, shortening of fornices. So we did. This is the procedure after removing all the fibrotic tissue. You have to deal with the notch too after incising and freshing the margins. An amniotic membrane has been placed. Always keep the epithelial side up and stromal side down, followed by this fornix forming suture. A needle is passed through the full thickness slit from the desired depth. This is him after 8 weeks. Another case, 56-year-old male, history of evisceration 10 years ago, and you can see next revenue. जी आप आगे आ गए. Okay. Here the issue is the oversize implant. So be very sure what implant has to be put at the time of primary surgery. And here is shortening of the inferior fornix and the superior fornix, and never use Prolene on sclera. This is him after amniotic membrane, after 6 weeks of surgery. Another child, 16 years old, history of trauma, thigh eye, unable to sustain a prosthesis. This is her after amniotic membrane grafting. These are few other cases post-surgical with and without prosthesis. So on conclusion, the advantage of amniotic membrane is that it is abundantly available and there is no need to sacrifice patient's own tissue, and it is simple and safe method for fornix reconstruction in blind and disfigured or enucleated sockets. It provides effective deepening of the fornix to retain the ocular prosthesis. A successful outcome can be achieved by selectively deploying cicatrix lysis, Symplifron release, and fornix reconstruction with AMT along with or without anchoring sutures. Thank you.
Our next presenter is Professor Ibrahim Hussain Sahab, and he'll be talking about orbital hematoma and rhabdomyosarcoma.
Bismillahirrahmanirrahim. So I'm going to discuss a tumor usually of children, and that's rhabdomyosarcoma. Now, these are the common malignant ocular tumors in children. The intraocular one are retinoblastoma, and very, very rare is the malignant melanoma. I have seen a child of 15 years with malignant melanoma till now. Then intraorbital rhabdomyosarcoma and Burkitt's lymphoma, and then secondaries to the orbit are common, and these are metastatic neuroblastoma, chloroma, and leukemias. Now, rhabdomyosarcoma is the most common soft tissue sarcoma in the children. About 4.5% of all cases of childhood cancer. And rhabdomyosarcoma is a malignant tumor of mesenchymal origin that is included in a group of small round cell blue cell tumors. And this is the distribution. Although only 7% of the orbit 7% of the tumors involve the orbit. Rest of these part of the body, you can see head and neck, extremities, genitourinary tract, trunk, and retroperitoneal. Now, most common orbital malignancy of the childhood, and incidence of about 4 to 5 per year per million children which are younger than 20 years of age. 90% of the cases present before the age of 20 years. The mean age of onset is 7 to 8 years. Slight male to female predilection is there, and it is about 5 into 3.4. Spread. Metastasis is uncommon. However, if left untreated, has a tendency to metastasize to lung, bone, and bone marrow. Locally, it can invade the orbital bones and can extend to paranasal sinuses and intracranially. Clinical features. Rapid onset of unilateral proptosis is a common feature to all these cases. Then eyelid edema and ptosis, extraocular motility is affected depending upon the size and location of the tumor. Again, the pupil RAPD may be there if there is it affects the optic nerve. Retina, if it is located posteriorly, it can lead to swollen disc and choroidal folds. Now, here you can see the presentation. The most common one, the upper left one, you can see this is the most common presentation, and it involves the superior orbit. This is a child, as Professor Tayyab discussed. I have seen two small children with congenital rhabdomyosarcoma. So this is a case of congenital rhabdomyosarcoma. And again, this is the less involved area, the inferior orbit. So the most common superior orbit and less common is the inferior orbit. So how to work up? Imaging studies is the most important thing, which can show you the location, the size of the tumor. The CT scan will show the bone erosion, while MRI will improve the definition of the mass and invasion of adjacent soft tissues. Biopsy is the mainstay, and you can confirm the diagnosis by biopsy, and it could be excisional or incisional depending upon the size and location of the tumor. Then PET scan is the recent new modality and usually used for to detect metastasis, which is rare in this case. Bone scanning is again needed to search metastasis of the bone. This is one of the tumor which can involve the bone. The metastasis can go to bones. Then there are some other investigations, including CBC, liver function tests, serum electrolytes, kidney function tests. It should be done before starting the chemotherapy. Now, this is the case of my series, the eldest one. He was 19-year-old. So the minimum is congenital, and the maximum here in my series of 12 cases, it is the 19 years of age involving the superior orbit. And you can see the MRI pictures. Now this is another case imaging. You can see the tumor involving the inferior orbit, and then here is the CT scan, which should be done to know the erosion, although it is located interiorly. But the CT is important in large tumors to exclude erosion of the bones, and this is the MRI picture. This is that congenital one. You can see a huge tumor, and the parents brought this child at the age of 1 month, and you can see the CT, and there is a huge tumor involving the anterior orbit, and there are multiple septa in it. What's the treatment? Treatment in patients with rhabdomyosarcoma involves a combination of surgery, chemotherapy, and radiation therapy. Now, because the treatment plan is complicated and prolonged, involvement of pediatric oncologist is must. Now, following biopsy, staging of the orbital rhabdomyosarcoma is internationally and uniformly done by intergroup rhabdomyosarcoma study classification. There are 4 groups. Group 1, the localized disease. When you perform biopsy, you totally remove it and you are sure that nothing is left there. This is group 1. Group 2, there you remove the tumor, excisional biopsy, but you are not sure and still some microscopic tumor is left there. That is group 2. Group 3 is a huge tumor where you try to excise the tumor, but still a large amount is left, either due to involvement of the structure you can't approach, or there are vital structures they got involved and you cannot remove the whole tumor. This is group 3. And group 4, when there is distant metastasis. Now, treatment depend upon this grouping. The group 1, in which you are sure that you have removed the tumor, still they need chemotherapy, and that is 2 drugs, vincristine and actinomycin. Then group 2, where microscopic tumor is left behind, a combination of vincristine, actinomycin, and cyclophosphamide is given, and this is followed by radiotherapy of 36 gray scale. Then group 3, where a large amount is left behind, a combination of chemotherapy, vincristine, actinomycin, cyclophosphamide, and radiotherapy of increased dose of 45 gray scale. And group 4, where there is a distant metastasis, a combination of intensive chemotherapy and radiotherapy is needed. Now, the European group, they have slightly different approach. They usually use ifosfamide instead of cyclophosphamide. The rest of the regime is almost the same. Then surgical care. Surgical management of rhabdomyosarcoma varies depending upon the location of the tumor. If feasible, remove the tumor promptly and without unacceptable disfigurement or loss of function. Because the orbit has got limited space and there are vital structures there. Therefore, some of the tumors you cannot remove until you damage the vital structures. So you have to be very, very careful. You should not damage the vital structures still you should remove as much as possible. Even if metastatic disease is present, surgical excision of the primary site should be performed if possible. Then surgical result helps to determine the clinical grouping to be used for treatment stratification. For tumors that cannot excise at diagnosis, a second look procedure may be appropriate after a period of chemotherapy. It means that chemo reduction should be done before removal of the huge tumors. Sometime I'll show you some cases where it was impossible to remove, or if you want to remove it, there is a huge amount of bleeding, so you have to perform chemo reduction first. Now, this is the original work, some 12 cases in the last 6-7 years, male 8 and 4 females. Then the average age is 7.2 years. So the minimum is 1 month and the maximum is 19 years, as I told you. Then histological types are also important, and the prognosis depends upon the histological types. The embryonal one is the most common. Fortunately, it has very good prognosis. Then alveolar followed by undifferentiated one. So these are my cases, 8, 3 and 1. Presentation, 7 of them, 58%. So you see 60% mass in the upper lid with proptosis. 25% patients with swelling in the lower lid and proptosis. 1 patient with proptosis and no lid swelling, and 1 patient presented with marked proptosis and swelling of both upper and lower lids. So you can see proptosis is common in all these 4 groups. Now these are my 12 cases. So you can see the different ages, but the maximum age, the minimum age, and the involvement of the superior orbit is more common. This is the inferior one, then again superior. So you can see superior orbit is the most common involvement. Professor Tayyib, I was telling them that you have already discussed this. This is one of my case which was congenital. In your collection, there are 4 cases. So in my collection, 1 case was congenital rhabdomyosarcoma. Now, intergroup classification, group 1 was 0. This is my own cases. So you see, group 1, 0 in our setup, the patient usually present late. So we don't see the group 1 patients where you remove the tumor, small tumor, and nothing is left behind.
So please conclude.
Okay. So the group 2, 16%, group 3, 75%. So you can see most of them are group 3 tumors where you remove the tumor and a lot of is left behind. Now, treatment. So the 4 patients received chemotherapy and radiotherapy. 2 patients underwent excision of the mass. But this chemotherapy and radiotherapy is after removal of the tumor as much as possible in the name of biopsy, which we perform first. 5 patients with huge tumors received chemotherapy first, followed by excision and radiotherapy. This is chemo reduction. Prognosis in good centers, 5-year survival rate is 95%. In our cases, 41% patients felt well at the end of last follow-up, which was 2 years. 4 developed recurrence for surgical excision and debulking of the tumor performed, followed by radiotherapy. And at the end of follow-up, 3 patients died of tumors and 3 lost the follow-up. So these are different cases. You can see small child. This is the huge tumor being removed. This is the post-op picture, and then she was sent for chemotherapy. This is another unfortunate boy. He came with this presentation, but the parents refused surgery, and after 6 months he presented with this much tumor. And then first chemo reduction was performed, followed by excision, and unfortunately, even after excision, he developed recurrence. This is another boy. You can see here. We removed the tumor, but there was recurrence, and then he lost. And then after 1 year, he presented with this. So again, chemo reduction was done and excision. And in this case, there was a involvement of the bone also. So he died. He died later on. This is the largest tumor I have ever seen, the rhabdomyosarcoma. So there was a recurrence and we debulk it, and there was recurrence. Finally, we lost this girl. Thank you very much.
Thank you very much, Dr. Ibran. Now, today, effect of
So, good morning, dear colleagues. Again, it's my pleasure to be with you in this wonderful meeting. So, my talk will be about intraorbital injection of amphotericin B in patients with orbital mucormycosis. So, we know that mucormycosis is a life-threatening disease. It's caused by opportunistic fungus from the microbial family. Usually, this fungus grows and invades tissues in patients with some predisposing factors like diabetes, cancers, and other immune deficient states. So the diagnosis of mucormycosis have been like a challenging situation. I will show you some guidelines about how to diagnose these patients and stay away from unnecessary, delay in treatment. Okay, thank you. Can I change slides from here? Can you do that? So I have no conflict of interest to any material in this actual presentation. So we talked about a life-threatening condition that may involve the orbit in about 66 up to 100% of these cases. So this disease is caused by opportunistic fungus in the tissue samples and the culture. You may see non-septate hypha. So the traditional treatment for patients with orbital mucormycosis and loss of vision have been exenteration. So this is the real appearance of the fungus. It's really beautiful. It's like a blue, shiny fungus. So the black fungus is a misnomer. So I remember when we actually faced the tsunami of mucormycosis, my friends in India started to spreading the word like it is a black fungus to raise the population awareness and governments to push and start something. So black fungus is misnomer, but we know in the tissues we have some black shards and black necrosis. So I found just a few months after COVID-19 that our cases with mucormycosis are rising. So I was like a referral for this deadly rare disease. So I rapidly found out that we have a rise in cases. So this is one of my early cases with mucormycosis in March 2019. And with orbital involvement and lung involvement, positive PCR tests. So we collected a series to show the awareness about this disease. But it was funny that our article was rejected for up to 6 months. Nobody believed that there is a true association between these two. So we found that with each spike of COVID-19, there is a rise in mucormycosis cases. So it actually helped us to predict the number of our patients in each spike of the COVID-19. So our study showed that unfortunately more than 2/3 of our patients had orbital involvement with loss of vision and loss of motility called orbital apex syndrome. So other studies later on, after this awareness, these figures a little bit changed. These are the host-related and actually independent COVID-19 factors for this disease. You may see COVID-19 per se is a risk factor, diabetes mellitus, and other immune deficient states, high cytokines, high ferritin. So why it's important? Because in every case with the invasive fungal, sinusitis and orbital involvement, if you have such predisposing factors, you should think about mucormycosis, unless you will have a considerable delay in diagnosis. How the orbit is involved? The most common route is here. Is here from the nasal cavity and from the paranasal sinuses, but the orbit may be involved. I had a couple of cases that the contralateral orbit was involved through the brain. So the fungus may come to the other orbit through the SOF or optic canal from the other side or from the PPF in the region. So I explained that in the case with these risk factors, you should think about that if you have any kind of the heralding signs and symptoms, and start intensive actually workup and start treatment without any delay. So we do not wait for any definite diagnosis to start treatment. After clinical suspicion, you should start the treatment. And yeah, I raised the population about these cases, but few articles then. And interestingly, we found that about 86% of our cases had diabetes mellitus and 48 had hypertension. In our first series, we found that only about 47 of our cases received high-dose corticosteroids. So at that time, some colleagues insisted that only those that had received high-dose steroids developed mucormycosis, but our study showed it's not true. As I told you that the most common presentation was orbital apex syndrome, it was very sad. We should diagnose these patients much earlier than that. And you may see among the symptoms and signs, oculofacial pain. This is later studies about the whole actually cases, about 270 cases. Orbital facial pain and periorbital edema were the most common symptoms and signs among patients with mucormycosis. So even with mild edema, even with mild facial pain, we do not wait for something bad happens to decrease the vision or something. We should start workup with CT scan, MRI, sinus endoscopy, and start treatment. So I would like here to mention, if you have clinical data supporting the diagnosis of the mucormycosis, but you have had no actual imaging or lab data available, you can say, I have a possible case of rhinoorbital mucormycosis. We can start systemic antifungal agents, start diagnostic workup. And if you have some imaging and clinical findings, now you can say it's probable. You can do lots of debridements in the sinuses. You do not waste your time for a lab to say it's like non-septate hypha in the specimens. And if you have available lab data, definitely you can say we have mucormycosis. And these are schema of the treatments for mucormycosis. Mucormycosis have two arms. First, antifungal agents. The second one is debridement, extensive debridement with different actually maneuvers. So we will talk about exentration. We are just focusing on the orbit. I'm sure that you have seen cases with mucormycosis. It's really destructive, not only for patient, family, and also us. After each exentration, I felt very sad, very bad in mood that night and the other night. So it's really destructive for all of us. So it shouldn't be that much easy to decide for exentration. And we have no clear definition when we should go for exentration in patients with mucormycosis, especially now we have evolving treatments of that orbital mucormycosis, but we know that if we have lost of vision, motility, and we have progressive disease, especially in the orbital apex, we can consider orbital exentration patients. So if we do exentration, does it make sense to patient? Does it change the survival of the patients? We have contradictory results in the literature. Some say, like Hargov, is among the patients with high risk criteria, they benefit, they gain benefit from exentration, but other studies showed there is no benefit doing exentration. You cannot increase the survival of the patients by exentration. So it's really difficult. But apparently, in those cases with apparent necrosis of the orbital and periorbital area, like in this case, you may see in the diffusion-weighted imaging, we have actually remarkable restricted diffusion showing ischemia and necrosis in the orbital apex, nasal cavity, and also the globe. And also, you may see in the contralateral eye, we are seeing medial rectus muscle enhancing, but in the involved side, you see no enhancement. It shows that we have no circulation tissues over there. We have necrosis. And this is after concentration. We are seeing that apex is involved, as was seen in this imaging. So I would like to mention about this very critical sign. So in the case with sinusitis, if you are seeing such a sign in MRI, the first diagnosis is invasive fungal infection. First of all, mucormycosis is called black turbinate sign. After T1 weighted fat suppression, get injection, you should see turbinates to be enhanced. If you are not seeing that enhancement, shows necrosis of the tissue.
A bit quick, please.
Sorry? Okay, I will finish very soon. This is diagnosis, and let's focus on intraorbital amphotericin injection. Historically, one of my colleagues in San Francisco, Reza Vagefi, found that patients that receive intraorbital amphotericin has less chance for exentration and no change in the survival. Another systematic review by Sharifi et al. Showed that those that received intraorbital amphotericin had better survival and better chance for preserving the eye. So now the intraorbital amphotericin B is kind of standard of care for patients with orbital mucormycosis. This is a guideline that we just published in the literature. It's one of the few guidelines about orbital mucormycosis to show how should we deal with this deadly disease. This is how we inject intraorbital amphotericin in patients. This is a video. I'm not sure I can play it or not. So the patient is awake. I'm talking to him. So we can just inject like the usual retrobulbar injection from the infralateral part of the orbit. But I found that if I inject directly through the lesion, I have better chance for preserving the actual orbit. And I usually do not use needle for injection. I use catheters. And you are seeing that after injections, that necrosis is disappearing in the patient. And this is just at the start of that intraorbital injections. This was a hopeless eye that was as a candidate for exentration by many of the colleagues. The patient denied, refused to be exentrated, and came to me. I started like the same that you saw, extensive necrosis in the apex and also brain involvement. So it's just 2 months after injection. The patient is actually alive now, as unfortunately blind, but still we could keep the eye. So you're seeing that no more necrosis in that area. So in conclusion, I can say that intraorbital amphotericin has superior efficacy for control of the orbital mucormycosis, and it's kind of standard of care for patients with orbital mucormycosis, and we can consider it like an orbital or globe salvage treatment. Thank you very much. These are my colleagues through the numerous studies. I was honored to work with them. Thank you.
Thank you very much, Dr. Farzad.
Very much. Thank you very much, all the participants and speakers. Very nice presentations. And Professor Abrar has to do some announcement, please.
A small announcement: the Pakistan Oculoplastic Association. No, there is a session here, so we will go to Kohinoor Hall for that meeting, please. Just now. POA.
Yeah.
So I enjoyed a lot of that presentation on rhabdo. I'm seeing lots of patients with rhabdomyosarcoma. I enjoyed really your cases were very tough. And I would like to mention, if I'm suspicious to rhabdomyosarcoma clinically after MRI, I immediately, the same night or tomorrow morning, I will go for biopsy. And after biopsy, if I am seeing the gross pathology compatible with the rhabdomyosarcoma, I ask my oncologist right away start chemotherapy. So I would like to mention that rhabdo is really invasive. We may see after 10 days, the whole picture, the whole stage of disease is totally different. I'm not sure what's your planning in these patients.
Our collaboration with the oncologist is not that good, I would say. So when we diagnose it, we clinically suspect it. We try to remove it as much as possible and send it for biopsy. And after the biopsy, we definitely send the patient for chemotherapy.
I want to make a comment as well. Chairman sir, Tayyib sir.
Oncologist, and then you have to have immediate radiation available. So these things are not available. That's what actually Professor Abrar is saying.
We can move to Kohinoor for further discussion. And another announcement is that the oculoplastic aesthetic session would be in Shalimar B starting 11 o'clock. So all of you are welcome to join Shalimar B for aesthetic. I think it is very important that Oculoplastic Association should increase the awareness amongst the members, because we should do it, otherwise a lot of other people are much interested in doing it.